Okay, moving right along to tumors. So most tumors, I mean, no, getting a brain tumor, getting cancer is horrible. Getting brain cancer has got to be just the worst, scariest thing. But actually, most brain tumors are benign. Really, the only malignant one you should, theoretically you should know everything. But the main one you probably need to know for the test is the glioblastoma as a malignant one. And I mean, a lot of the damage these are going to be doing is just due to increased intracranial pressure and a mass effect, right, causing like an uncal herniation or a subfalcine herniation or whatnot. But you can see with the benign, we have these well circumscribed regions, and the malignant's a little bit more chaotic, a little bit more all over the place. And yeah, this is a real son of a bitch, this section. There's a ton of tumors, and the organization is kind of confusing. And in case it wasn't clear, our grapefruit is the brain tumor. But technically, it shouldn't even be brain tumor because we're also going to be talking about peripheral nervous system. So this just means nervous system. Let's just simplify it. All right, let's jump in. We'll break it down. So endocrine, anything hormone related. We have pineal gland tumors. Actually, one more thing I wanted to say. So yeah, we should know glioblastoma is the main malignant one. I would also know that meningioma is the most common one overall, and then pituitary tumors, specifically a prolactinoma, is also quite common. Okay, back here. So we're talking about pineal secreting melatonin, pituitary secretes a bunch of stuff, and then the cranial pharyngioma as well. So the pineal gland, remember that this sits right here, the dorsal aspect of the thalamus and hypothalamus. And if you have a swelling here, it's actually going to obstruct the dorsal midbrain. And we've already been through this. Vertical gaze, palsy, you're going to have lid retraction, which is Collier's sign. We saw these kids with these sunset eyes. And then we have this light near dissociation because the Edinger-Westphal nucleus is being compressed. So you won't restrict for light, but you will restrict for accommodation for things getting near to your face. Randomly, it's going to secrete HCG, which can lead to precocious puberty. Pituitary. So the pituitary, very, very high yield. I've said it a million times. Here's a pituitary. It is going to, here's also a pituitary right at the optic chiasm, right at the optic chiasm, right at the optic chiasm, right at the optic chiasm. So if this starts to swell, it will compress the optic chiasm and you will get bitemporal hemianopsia, where you lose your temporal vision on either side. Pituitary apoplexy, the tumor for whatever reason can hemorrhage. This can lead to vision loss, as you can imagine. It's right at the optic chiasm, but it's also going to increase the intracranial pressure and can cause headache and vomiting. The vision loss I'm saying is because of intracranial pressure in the optic chiasm. I hope that was clear. So 2/3 of pituitary tumors are actually functional. They're hyperfunctional. They're secreting way too much of the hormone. 1/3 of them are silent and non-functional. Lactotropes by far is the most common one. So these are going to be prolactinomas, secreting prolactin. And I think of this as being just in adults, not kids, because adults make milk and not kids. So it's going to be excess milk production in breast tissue. And the whole, if a mom is breastfeeding her kid, she's lactating, just evolutionarily, if you got one kid that you're breastfeeding, you're probably not ready to get pregnant again and divert a bunch of resources and nutrients that are probably scarce. So as an evolutionary adaptation, people who are breastfeeding, the prolactin, which stimulates the breast milk, also is going to have a dual secondary effect of suppressing gonadotropin releasing hormone, so that women do not, no FSH and no LH, so there's no estrogen, so there's not a period. But if this is, we're hyperfunctional, we have too much of this. If we don't have estrogen is necessary to inhibit osteoclast, so you can get osteoporosis. It's not even supposed to be a thing in men, but if men have too much prolactin, I guess they can start lactating, but it's going to have the same effect on the HPA axis. It's going to suppress GnRH. It's going to lower libido and can lead to infertility. Dopamine is interestingly the prolactin inhibiting factor. So dopamine agonists like bromocriptine will be therapies for this. Somatotropes with growth hormone. If kids have too much growth hormone for a long time, they can become, gigantism. If adults have it, they're pretty much, I think their epiphyseal plates are fused, and so they're not really growing, but their hands and feet and face might fuse, might grow. So this is called acromegaly. And then corticotrophs is going to be releasing responding to cortisol releasing hormone, secreting ACTH. We have Cushing syndrome, which is just anytime you have too much cortisol, but it's specifically Cushing disease if it comes from the pituitary gland. And, we have the stria, we have the, truncal obesity, and then the buffalo hump, and the thin skin, and the high blood sugar, and et cetera, et cetera, et cetera. Craniopharyngioma. This has to do with embryology. Anything have to do with embryology, anything with the name blast, that's going to be kid related. So, Rathke's pouch. So it's interesting in a very not interesting way. But you look at the anterior pituitary and the posterior pituitary, and you just assume they're just besties, identical twins for life. Turns out that the diencephalon, just basic nervous tissue, is going to make up the posterior pituitary. The anterior pituitary actually comes from oral ectoderm. That's just fun trivia that they like to ask you sometimes. But so these do have different lineages from embryological tissue. And again, anything embryological is related to kids. And it is, though, near the optic-chiasm. So this could also cause bitemporal hemianopsia. So again, neurovasculature. So this is blood vessels lining the nerves. Hemangioblastoma is going to come from blood vessels. Could be pericytes and endothelial cells in the brains. And we're going to see thin-walled capillaries with not a lot of brain tissue on histology. We know that EPO is something the kidneys can secrete to stimulate blood production in the bone marrow, but it actually also is going to produce, as a couple smaller, lesser-known roles, it also is going to promote angiogenesis, which would make sense if you're a cancer based off of blood vessels and you want to grow. You would like some molecule, some hormone that is going to promote blood vessel growth. So kind of makes sense then that they're producing EPO. So we know that the cerebellar is highly prone to strokes, and that's because it's highly vascular and it's super large. So a combination of it being very vascular and very large just means there's a good chance that this is where your hemangioblastoma is going to appear. It appears in the cerebellum. We had the hippocampus with the cerebellum for watershed areas, but now you can also remember you can actually just think of von Hippel-Lindau with the bell. It's silly and that's stupid, but whatever helps you remember it. Hematopoietic. So we can have primary central nervous system lymphoma. This is an HIV/AIDS defining brain tumor. And this single ring enhancing lesion. It's single. It looks very much like toxoplasmosis, but I always thought cats have 9 lives and this has 9 legions. So the difference is we have 1 legion over here and several legions for toxoplasmosis. Peripheral nervous system. So we have the nerve sheath tumors, but then we also have neuroblastomas. So let's get into it. Again, we see the word blast, we should think kids, and maybe embryological relevance. So remember that the adrenal medulla is derived from the peripheral nervous system, from the neural crest cells, which become part of the peripheral nervous system. I remember that is the adrenal medulla has catecholamines. These are neurotransmitters we typically find in the nervous system. So if I have a structure outside of the nervous system, it's not really doing a good job of hiding its cover, its tracks about its ultimate origin, right? So it's we can spot, you used to be a neural crest, and here's the evidence. Anything blast has these homerite rosettes. And they kind of just look like it's like a rose. And arguably they kind of look like a rose. I don't know how much I see it, but they have these things called neuropils, which are just unmyelinated axons in the center. So if this is the adrenal medulla, so here's our, adrenal is near the renal. So here are kidneys, and then right at the top of the kidneys are the adrenal glands. So you might have a firm mass where your adrenal glands are. You could have it in other places as well, because the sympathetic chain, you could also get a neuroblastoma there. And you're going to get excess catecholamines, which is going to cause hypertension. And, and this hopefully should make sense, right? It's the adrenal medulla. This is making the catecholamines, which cause hypertension. So you're going to have more of that. And then these eventually are going to be, I think, monoamine oxidase and other enzymes are going to break this down into homovinylic acid and some other thing that I forget, HVA and MVA. Nerve sheath tumors, so we have schwannomas. It's going to be adults. Neurofibromas, it's going to be kids. The schwannoma, it's a Schwann cell origin. This wraps in the peripheral nervous system, and classically at the cerebellopontine angle. So pons, cerebellum, and here's my angle. That's my theta, right? So this is going to be near the internal acoustic meatus. So these are called acoustic neuromas, also known as vestibular schwannomas, and it's associated with neurofibromatosis type 2. One of the stains that we should keep in mind is S100, which just in general is going to be in a lot of neural crest cells. This might mimic in like the clinical symptoms, the presentation, what Wallenberg syndrome is, where we have a pica infarction in the lateral medullary, which causes hearing loss and tinnitus and balance issues and dysphagia and dysarthria. Technically, hearing loss is actually a little bit more AICA than pica, but you can ignore that. The Schwann is usually the cerebellopontine angle. You could have it in the periphery as well. Mostly it's going to be here, interacting with this. Neurofibroma. So a schwannoma is kind of like nicely circumscribed, and it's mostly just these Schwann cells over here. The neurofibroma is a hamartoma. It's a bunch of collagen, a couple Schwann cells. We got some axons, we got some mast cells, we got a bunch of random shit in here, which actually means that it's really difficult to remove these without sacrificing the underlying nerve, because it's just a bundle of stuff together, and it's hard to take out just one bit without taking about a bunch of the other stuff. Also with schwannomas, we typically just have this one big schwannoma. Here we have these several little cutaneous nodules all over the body, everywhere. Associated with neurofibromatosis type 1. So someone's born with this, and they're just going to develop more and more of these over time. And they're going to get larger and larger and larger. All right, central nervous system, we made it. Looking at just neuron tumors, retinoblastoma, I think R for the retinal cells, and then B for bone. Now, in the eye specifically, if I take a photo of you, we have something called the red reflex, where the light hits your eye and it bounces off as red. You can see that picture right there. But if you have a tumor, for whatever reason, the light bounces off, interacts differently, and it bounces back as white. So you have this loss of the normal red reflex, and you get a white eye instead. So the name is leukocoria. This is the white reflex, basically. And just a quick refresher, P53 inhibits P21, P16 inhibits, the P21 and P16 are both inhibiting these cyclins. What are these cyclins trying to do? Well, retinoblastoma is normally, it's a tumor suppressor. It's inhibiting E2F. E2F, epidermal growth factor. It wants to divide. It wants to cause cancer. But luckily, we have retinoblastoma who's on our side, which is holding it down. But these CDK cyclins are all about cell growth. So they're going to go and phosphorylate this RB protein, and that inhibits it. It is now turned off. E2F is free to go and cause cell division. So when you have a loss of this tumor suppressor, mutation of this tumor suppressor, that is why you get this cancer. All right, CNS embryonal tumors, so medulloblastoma. So again, anytime you see blast, we're talking about embryonic, and we're talking about kids. And we're going to be dealing with the homocyte rosettes. Boom, there you go, right? That's just, I think, a really helpful tip. These are classically going to be in the cerebellum near the medulla, and this can affect specifically the vermis and the spinocerebellum and like the center. And this is where we get proprioceptive inputs from the dorsal column, the medial lemniscus. So you're going to get truncal ataxia. In being in the cerebellum right here, it can compress on the fourth ventricle, on the aqueduct of Sylvius, and this can cause an obstructive non-communicating hydrocephalus. So this increases intracranial pressure. So you can get papilledema, increased blind spots. You're going to get headaches, nausea, vomiting, and a drop metastasis. So this is a rare tumor, and it's a rare thing within this, but it can now spread downwards through the spinal cord, even going all the way to the cauda equina. So that's not really common, but that, could happen. And we see evidence of that right there. All right, so glioma. So these some of the more important ones to know. Often these are only going to be in the brainstem or in the optic region. So we have oligodendrocytes, we have the meninges, then we have the ependymal cells, and then we have the astrocytes. So a oligodendrocyte, these are going to wrap multiple neurons with myelin. So one wrapping multiple neurons. I think of egg, egg. So these are oligodendrocytes. This is our egg. There's a chicken wire capillary pattern. There's a fried egg appearance. What do I mean? This is our fried egg. This is our chicken wire. And how does that map onto this? All right, so get ready for a super awesome animation. All right, so I'm going to minimize these. I'm going to move it over there. Boom. So let's go back one. Here's our egg. Here's our chicken. And boom. That's it, right? So you can kind of see it now a little bit. Eggs are also made up of calcium carbonate, and there's going to be calcium deposits in oligodendroglioma. Meningioma, these are just the most common. They're most common. You should know they're benign. Really, the only thing that you have to think about that's not benign is the glioblastoma. So it's the most common one. Know this. It's the arachnoid layer. That kind of makes sense. Most of the other layers are just kind of like connective tissue fillers. There's actually like metabolic activity. There's stuff going on interacting with the cerebrospinal fluid. It's also got like kind of more volume than the other layers. So to me, it makes sense that this would be affecting the arachnoid layer. And it might look like an epidural hematoma, right? So you should keep in mind that meninges are on the periphery. And so that's where you should be able to quickly and immediately identify this if you're given it on the test. It's going to look different than an epidural hematoma. An epidural hematoma is quickly filling with arterial blood, and it's not allowed to cross sutures. And so you're going to get this, I think I said crescent earlier and I misspoke, you're going to get this nice lens shape to it, this convex lens shape. But here, this is just a slow-growing tumor, and it's just going to grow outward. It's going to be a little bit more spherical, so you should be able to tell them apart. You're also going to get Samoma bodies, and one of the M's here is for meninges. One of the other P's, I don't know if I mentioned that, was for prolactinoma. Ependymoma. These are the cells that are part of the choroid plexus and the ventricles. These are generating cerebrospinal fluid, and if you have a cancer here, you're going to block the natural order, the natural flow of things. You're going to get an obstructive, non-communicating hydrocephalus. So every time we saw blasts, we saw rosettes. Those are Homer Wright rosettes with little bits of unmyelinated axons in. Here we're just going to have a rosette. So this is a rosette for the Homer Wright, anything blast. But here we're going to have rosettes, but they're just empty on the inside, empty lumen. All right, astrocytes. This is important. You can form a low-grade astrocyte. This is often going to be in kids, could be in adults too. But this is now it can potentially transform over to a glioblastoma. I think you could probably get a glioblastoma immediately, but I think it often goes from an innocent low-grade astrocytoma to it transforms to a glioblastoma. So this is quite common. It's the most common one in kids. It's an astrocyte origin. It's low grade, so it's mostly functional, and it's still well differentiated. It looks like a normal cell. And these have this glial fibrillary, I think like acidic protein, accessory protein. I thought it might be acidic protein. Suspect. Google that. Not that it's probably that important. So this helps make a protective mesh after an injury. That is the whole point of what astrocytes do. One of the things they do is reactive gliosis. Forming like scar tissues, and they use this GFAP to do that. So this is a common stain for astrocytes specifically, and if it's a common stain for astrocytes, well then it's going to be a common stain for astrocytomas because they're functional. They are still producing a lot of GFAP. Here is before an injury, and here is after an injury. We have hyperplasia and hypertrophy of the glial cells, and so we're going to get a lot more green. These are going to have something called the Rosenthal fibers, which are just clumps of GFAP that we're going to see in histology. Now, astrocytoma could be pilocytic, could be giant cell, probably pilocytic. These are going to be hair-like projections. So we said that the astrocytoma can we could jump straight to, an astrocyte can become a glioblastoma, I guess, immediately. But usually it becomes an astrocytoma and progresses over time to a glioblastoma. Glioblastoma, I always thought of like, it's like a butterfly gliding. So people might call this a butterfly tumor. It kind of looks like a butterfly. I think of it more just as the fact that it's clearly not a well demarcated tumor. So that's how I know it's the malignant one. And I just remember, I don't know, butterflies glide. And so that kind of looks like a butterfly. Um, and yeah, they're very high grade. They still have some GFAP, but they're very high grade, so they don't look like normal cells. But they have these, they're described as pseudopalisading cells that surround a central, necrotic core. So here's our palisading cells. Here's our palisade, and here's our center. Here's our palisade. Here's our central necrotic core. Okay, great. So there's our little overview. And this is the place where you might find a lot of these particular tumors. And important to know, adults versus kids. So adults produce milk. Prolactinoma is going to be adults. Hemangioblastoma, adult. People who have HIV are typically adults. A schwannoma, I think of like an ugly duckling. You talk about a kid who's not very attractive, and they grow up to be quite beautiful or handsome. So that's the schwann. The ugly duckling grows up to be a schwann. That's an adult. They've grown up. Oligodendrocyte, who lays eggs? Adults. Meningioma, men are adults. I don't really have one for this. Memorize that. Kids need their sleep. Craniopharyngioma, cradle. Anything with blast is going to be kids. Blast is going to be kids. I just know that this is a genetic thing, so I know it's going to affect kids. And you hear about kids often, something being detected, and maybe kids take lots of photos, and you're going to see the loss of the red reflex in the leukocoria. Appendimoma, so I think of like someone calling mama, and that's a little kid. And then astrocyte, I think of like Astro Boy, that's a little boy. Remember that blasts are for stem cell precursor cells, and that's also, again, kids. That's, less differentiated, etc. So again, most of these, meningioma is the most common one. Glioblastoma is the most common aggressive malignant one. Prolactinomas are very common, and astrocytomas are also very common for kids, right? Astro Boy. Lung is very common. Breast cancer is very common. Colon cancer is very common. All of these metastasize to the brain.